With these lectures, we began looking at diseases of the heart itself. We've been looking at blood vessels in the previous ones, and so now we move into issues with the heart. We're going to start with the pericardium. This is a little out of sequence with how Chapter 19 goes, but I like to work from the outside of the heart in, and so we're going to first start with looking at the pericardium. So that's the outer layer of the heart. If you're not familiar with the layers of the heart, this picture just gives you a quick review. I'm not getting into the details. Pericardium actually has several layers in it of itself. We're just going to deal with pericardium in general, not the fibrous, thick outer layer and then that thinner visceral pericardium. We're not going into all that. But we have pericardium, epicardium, the muscular layers of the myocardium, and then the inner layer, which includes the valves, is the endocardium. And hopefully you recall from your AMP2 that the endocardium is continuous with the endothelium. That's the blood vessels that are the layer that lines the blood vessels. So endocardium, endothelium are the same tissue, allowing for continuous blood flow. But we're going to start here with the pericardium. Here's just another picture, so I forgot this was here. Just reviewing those layers again one more time. And it is important to note that between the pericardium and that epicardium, that that outer layer of the heart right against the muscle of the heart, there is a cavity or space, the pericardial cavity, and that's important in terms of fluid accumulation. There is always some serous fluid in there. There shouldn't be excessive, but that's going to be a problem with pericarditis, which is where we're going now. So, starting with the disorders of the pericardium, pericarditis, inflammation of the pericardium, has numerous causes on our chart here. Chart 19.1 lists a whole bunch of them. Don't go trying to memorize them, or even, it's not even necessarily anything I ask a lot about or focus on, other than to make note that not every pericarditis or inflammation is linked to an infection. So we've got, certainly there can be viral and bacterial infections that cause that inflammation to occur of the pericardium, but there's lots of other things. You see autoimmune disorders, metabolic disorders, myxedema, we recall from hypothyroidism. Any kind of cardiac surgery or cardiac trauma can lead to this sort of inflammation. There's medications that can do this. Cancers will do this, and then there's congenital disorders. So lots of things can lead to that inflammation that occurs. We're going to look at two kinds, acute, which should take you back to the inflammation lecture and all that goes with acute inflammation. And so one of the biggest things you should recall is the type of blood cells, white blood cells that are involved. There's a lot of granular white blood cells involved, but even more importantly, you hopefully will recall that with acute inflammation there's exudate, and that's one of our biggest concerns with pericarditis. Also think about what are those cardinal signs, those trademark signs of inflammation. There's that redness, that pain, that heat or feeling, but there's also swelling, that tumor or swelling. In inflammation, you will find that pericardium, let me just jump back here for a second, jump back here, this pericardium thickens, and then exudate is produced because this wall is inflamed, and the fluid starts to accumulate here in the pericardial cavity. Now, in a general sense, pericarditis will start to apply some pressure. It doesn't usually come on too rapidly. It's acute, so it's coming on within several days, but not necessarily several hours. So it's not a rapid influx of that exudate. It takes a little bit of time. It may be 24 to 48 to 72 hours, say, for that inflammation to occur. Now, some of the manifestations are the same whether it came on super fast or not, but we'll talk about that in just a second. But the idea is I want you to be thinking about, even if we just look back here at our full heart, if we see this outer layer start to thicken with swelling, inflammation, and fluid buildup within that cavity, it's going to push against that cardiac wall itself. Remember how blood flow works and what that process is. Remember the concept of preload. Preload is the concept of the Frank Starling law of the heart. The greater the degree of stretch, the greater the force of contraction, and it's very much linked to end diastolic volume, or the return of blood. So as blood is coming in from the superior and inferior vena cava or through the pulmonary veins back to their left side of the heart, as the blood pours into the ventricles and eventually is squeezed in when the atria contract, we'd like to see these areas fill. So in ventricular diastole, there should be an expansion of the ventricles so that they can fill with blood. If this wall is thickening, this pericardium is thickening, there's not enough room for the heart to expand. It starts to apply pressure, making it very rigid, and so it can't expand preload. The ability to fill and stretch is greatly impeded. And so the more fluid that starts to accumulate in this space, or in this, if we look here, the more fluid that's in there, it pushes against that wall. Remember how muscle contracts actively and then relaxes passively. And as the ventricles relax, they should expand to allow blood to get in. So this is a huge problem with affecting preload. It's going to inhibit the ventricles from relaxing and filling, and therefore less blood comes in means less blood going out. So cardiac output is going to decline. So again, when we look at causes, there's all kinds of things for the causes of acute inflammation. Primarily we are talking about more commonly viral and bacterial, but any number of these things. And then that manifestations is what it does to the heart wall. It impedes the ability for the heart to relax. So therefore we have a decrease in preload. We will have issues of reduction in cardiac output. If we reduce cardiac output, that means we're reducing the amount of oxygenated blood that goes out to the body. It slows metabolic rate. So we have a real problem. The heart's going to try and beat a little faster, but it's not that faster rate will not necessarily compensate. So we will have tachycardia. The patient may very well have chest pain, so there'll be some extreme pain. They'll feel anxious, or anxiety will develop because they're trying to figure out why is it they can't get oxygen. They feel this pain. They think they're having a heart attack. And it's not that this cannot lead to myocardial infarction. It may, because if we're not delivering blood, if we're not delivering blood because we don't have as much out the aorta, recall this picture doesn't show it here. In fact, let's just jump ahead for just a moment. Here's our coronary arteries. Remember that the left and right coronary artery receive blood as blood is pumped up the aorta, and then as soon as the pressure drops and blood starts to flow back down a little bit, that's how blood gets into the right and left coronary arteries. So with each beat, blood is pushed up, and then as it starts to flow back, it enters into the left and right coronary artery and gets caught up in those aortic valves, so blood doesn't flow back into the left ventricle. So I'm hoping, I know I said that fast. That's an A&P2 topic as well. You've got to know why those, or how those left and right coronary arteries fill with blood. But what's at issue here is that if I don't have enough blood going out because I can't fill, because I can't expand, because all this fluid is pushing against the wall of the heart, I'll have less blood that goes into the coronary arteries. If I have less blood delivering to the coronary arteries, the same as I have less blood delivering to the rest of the body throughout the aorta, eventually I put my heart at risk for a myocardial infarction. And we'll talk more about coronary artery disease in just a moment. Let me back up again here. So your biggest manifestations are, you'll have some tachycardia, but your preload's going to go down because you're not going to get enough blood in there. Your cardiac output is going to go down, and you're certainly going to have chest pain. Let me talk about constrictive, and then we're going to talk about some specific kinds of pericarditis. So constrictive pericarditis is different. In older versions of the textbook, if any of you are using an older edition, something before the 4th edition, there was also a chronic pericarditis listed, and then constrictive. And really, chronic pericarditis is extremely uncommon. In fact, it's more associated with maybe some fungal infections, and really it's more constrictive. So I think our author has removed the chronic pericarditis and replaced it with constrictive. So again, if you have an earlier edition of the book, that might be a little confusing. We're going to merge those two concepts together. So constrictive pericarditis is when there is the development of a fibrous scar tissue between the layers of the pericardium. So within that cavity, it's scar tissue. It can develop as a result of ongoing acute inflammation that instead of becoming really chronic, they are calling it constrictive. The issue with constrictive pericarditis is that tissue, that scar tissue, that layer of connective tissue that forms in there, won't go away. This becomes a permanent condition. You see some very significant manifestations that go on here. The heart wall becomes more rigid because, again, it can't expand. So you have that same manifestation of an inability for the heart to expand, but now you can't resolve it with some antibiotics or by you can't do anything about this. Someone who has constrictive pericarditis is actually someone who may be placed on the list for a heart transplant, because this issue is not something that can easily be resolved. Some of the other manifestations that you will see, edema forms from this, particularly ascites is associated with constrictive pericarditis. There's something called Kussmaul's sign. It's Kussmaul. We'll talk a little more about Kussmaul's sign in the when we do Kussmaul's breathing as well, because they're associated. But Kussmaul's sign, so we'll do it more with respiratory, but let me give you a brief definition for it here. Kussmaul's sign is distension of the jugular veins upon inspiration. So in an inhale, what happens is the venous return increases as you inhale, because that's the respiratory pump pumping the blood back. And so as you inhale, what it actually does is push the blood kind of backs up into the jugular veins, because there's no place for the blood to go. It can't get in the heart. There's no room. So it backs up into the jugular veins, and you see them bulge on the patient's neck, particularly with inhale. So when those jugular veins bulge, we refer to that as Kussmaul sign. That sign occurs with other conditions. Constrictive pericarditis is not the only thing. You will see it in some heart failure, for instance, as well. So I don't necessarily need you to link it directly to constrictive pericarditis. Just start to be aware of it. And then when we talk about Kussmaul's breathing, it's notice I said that happens when you take a deep inhale. Kussmaul's breathing is a rapid, deep inhaling or respiration or ventilation. But the Kussmaul sign in terms of the jugular veins is linked to that deep inhale and that respiratory pump pushing the blood vessels and pushing the blood back up into the jugular veins. So again, constrictive pericarditis, that thick connective tissue forming in that pericardial cavity or between the layers of the pericardium. There may be some surgical removal or resection that can be done, but oftentimes, depending upon the cause of this, if it's fungal infections or other chronic conditions that can lead to that, it may be a terminal condition for that heart, and not much can be done for it. Again, cardiac output would also be low with this one as well. Same thing as you would find with acute. Pericardial effusion is really listed as a separate disease. Your book puts it as a separate area, but pericardial effusion is very, very often linked to pericarditis. Accumulation of fluid in the pericardial cavity. So it's one of those third spacing. Causes for pericardial effusion: trauma, infection, inflammation, surgery, cancers, neoplasms. All of those things can lead to pericardial effusion. The manifestations are very similar to pericarditis. I don't need to go through them all again. The issues there are, again, the heart doesn't have room to expand. Here's a good picture of what can happen when you have a really large accumulation. See, this is the pericardium here, and you have this large accumulation of fluid pushing against the wall and not allowing the ventricles to relax. I'm sorry, the picture is just a little bit blurry, but you get the idea of how the heart muscle is affected, how its shape changes because of the fluid that's accumulating in there. And it can be in this picture it's blood, but it can be other kinds of fluid that are causing an accumulation in there. Cardiac tamponade is a very distinct form of pericardial effusion. This is one that usually comes on very rapidly. It's often linked to bacterial or viral infections. And cardiac tamponade, again, just a severe form of pericardial effusion that comes on very quickly. This accumulation requires that fluid be drained. Patients in cardiac tamponade often think they're having a heart attack, and It is a life-threatening condition because the cardiac output, the stroke volume and cardiac output will decrease significantly. Again, think about what's going on here. If there's accumulation here, there's just no blood that can get into those ventricles. There's no room. They're not expanding, and therefore cardiac output will drop dramatically. So that's a big issue with cardiac tamponade. Again, many times patients will think that they are having a heart attack, and in fact, when they're called to the ER, it's upon listening to the heartbeat and auscultation that you can oftentimes can hear that fluid accumulation in and around the heart and recognize what's happening, and that fluid then has to be drained very rapidly. Oftentimes treatment, if it's viral, there's nothing you can treat for, and it simply has to be drained and let the body and the immune system attack it. Okay, so those are the disorders of the pericardium. All right, we looked at this picture for just a moment earlier, but these are your coronary arteries. I don't ask any specific questions about the locations, names of the coronary arteries, although I refer to them. So if you're not familiar with the coronary arteries, you might want to take a look at this and just go through that. And again, remembering how the blood fills into the right and left coronary artery, which feeds the entire heart, left and right side. So what we're going to look at here are disorders of the coronary arteries leading to coronary artery disease. And so there are basically two things we're looking at. In coronary artery disease, we're talking about plaque buildup in the vessels, and we're either going to be dealing with acute coronary syndromes or chronic ischemic heart disease. And so in order to understand the difference between those two, you've got to see how the difference changes in the blood vessels. And so you should be familiar with the term angina. Angina is chest pain. Well, we use this also in terms of looking at the condition of what's actually happening with the plaque buildup. So here's your blood vessel. See the lumen of your blood vessel with no plaque of any kind built up into it. There's the layers of the blood vessel listed there. Here you have the plaque that's starting to build, and now it's getting larger. There you've got the foam cells in here. You don't have that plaque cap forming yet, no thrombus, no major obstruction. But this is going to definitely affect the ability of blood to flow through. So we call that stable angina, and we don't have a tear in the vessel at this time. We certainly have occlusion or blockage of the vessel. So in stable angina, there is stable atherosclerotic plaques. This is stable plaque, which leads to what we refer to as stable angina. And so we'll talk about stable angina with chronic ischemic heart disease. So we're going to come back to this one in just a moment, because we're going to first look at acute coronary syndromes. And so we need to look at these three here for this to make sense. And you see they're labeled as acute coronary syndromes. When you have unstable angina, what you have here is what's referred to as unstable plaque. You have the tear in the vessel has started to occur, the plaque cap is forming, the obstruction's a little bit larger, a little more rigid, and again there's more damage to the blood vessel itself. In unstable angina, the first of the acute coronary syndromes, this person who has this unstable angina is not at the moment going to be one that would be undergoing a heart attack or a myocardial infarction. So acute coronary syndromes are really, we're getting ready to talk about heart attacks. But an unstable angina, you're not yet having a true myocardial infarction. Infarction means death of cells, and myocardial is the type of cell. So we do not have any dead cells yet. In an unstable angina, you have to have at least one of these features. I'm going to run through this list. Here they are. If you have unstable angina, you must have pain that occurs at rest and lasts for more than 20 minutes, or you must be severe and described as frank pain of new onset. Frank pain means it's very distinctive pain. It's very strong. We don't use the word severe because it's not quite at that point, but it's like it's very pointed. You feel it in the chest. It's strong, frank's kind of an unusual term, but when a person has it, they're like, yes, it's a very frank. That seems like the right way to describe that pain. It's right at that point. It seems very sharp, but yet it's not quite like a stabbing pain. So it's frank pain of new onset. And again, you can have more than one, but you just have to have at least one. And it occurs with a pattern that is more severe, prolonged, or more frequent than previously experienced. So again, unstable angina is not, it's acute coronary syndrome because of this type of plaque that's involved, but we are not talking about a heart attack here. And then you have the two forms of actual myocardial infarctions. They're both heart attacks. Now, your book goes into a lot of detail here. I do not want you going into that kind of detail. I won't be requiring, there's a lot of discussions about biomarkers and other chemicals involved and the process of the death of the heart cells. We do not hold you responsible for that content at this point in your education. Depending upon which major you go into, you'll get more content there. But there are two kinds of myocardial infarctions, and they're linked to our picture here with the non-ST segment elevation MI and the ST segment elevation MI. And notice the difference between what the actual blockage in the vessel looks like. In a non-ST, it's not fully occluded or blocked, but in an ST, it is a much more severe, really usually 100% blockage. So in the non-ST elevation, I often refer to it as the N-STEMI, you definitely do have death of cardiac cells. It is, if I look back at my coronary arteries, a vessel's been blocked. Blood flow is not going to that area, and those cells of that myocardium are dead, or they have died. How do we know it's a myocardial infarction? Because when cardiac muscle cells die, they release certain chemicals. That's the biomarkers the book goes on and on about. I don't need you to know the kinds of chemicals. I don't need you to have to name them at this point. I simply need you to know they exist. There are chemical markers, biomarkers, that indicate that can only be in your blood if cardiac muscle cells have died. So they run a blood test. They've done your EKG. I hope you know that an ST elevation, the ST is where the contraction of the cardiac muscle is seen on an EKG. And so they run, and it's the ventricle contraction, not the atrial. And so they look, and the EKG says the ST segment is not elevated. It looks normal or relatively normal. And we do see biomarkers. So we draw blood, and we see biomarkers that can only be there if cardiac cells have died. You've had a heart attack. The odds are in an N-STEMI, you will not die. Again, there are always levels, but it is the least severe of the heart attacks. And there's definitely been damage to myocardial cells. Now, the acute ST elevation myocardial infarction, you'll recall from the previous picture, that's fully occluded vessels. This is extremely severe. This is the STEMI. The ST segment is biomarkers are the segment elevation. Will tell right away the patient's having a heart attack. You won't need to pull blood in order to confirm that time. It tends to come on very abruptly. It has a very severe crushing chest pain. This is the one that radiates off into the left arm, neck, or jaw. If you give the patient nitroglycerin, it will not solve the problem. So they will still have the pain. It will continue forward. There's often epigastric distress. Epigastric distress is nausea and vomiting. There's increased sympathetic stimulation because the body is saying something's happening to my heart, something's happening, it's not beating, and with that you have tachycardia. There's definitely anxiety. The skin becomes very cool and pale, and they may perspire. Their body's rerouting as much blood as it can to the heart, taking it away from the skin. And of course the person will become hypotensive. The heart's not pumping, so blood pressure will begin to drop rapidly, and they'll go into shock. And oftentimes a STEMI does lead to death. So not every N-STEMI is mild and nothing, and not every STEMI will lead to death. But they're the two ends of the spectrum, and there's a range that you move through in between. So those are your coronary artery diseases, acute coronary syndromes. Unstable, not a heart attack, but we are talking about acute syndromes because we've got a plaque cap forming. These two are actual heart attacks. Then you have chronic ischemic heart disease. So this goes back to our stable angina picture. And so if you look back here, here's the stable angina. We're dealing with this kind of a buildup. And there are 3 different kinds of chronic ischemic heart disease. In chronic stable angina, or sometimes just referred to as stable angina, you will find this in probably over 50% of the people who have coronary artery disease are in this stage, so they've not progressed all the way through. There's chest pain upon exertion, or if there's emotional stress, or even sometimes if there's exposure to cold, there can be, because your body's asking for more. There is pain associated with chronic stable angina, but it won't be as severe as a full-blown MI. Silent myocardial ischemia is ischemia with lack of angina pain. You see this most commonly in the elderly, because sometimes the elderly simply don't respond to pain in the same way anymore. A lot of their receptors have numbed over time, and they simply may not recognize that they're even having chest pain. They have aches and pains all the time, and they don't recognize it. They don't exert themselves very much, so they're less likely to feel it. Also, those who suffer from diabetes mellitus, there's a lot of neuropathy or numbing or loss of sensation to nerves with diabetes mellitus. And so the autonomic nervous system oftentimes doesn't give the signals. The sensory side coming back to the autonomic is not always functioning as well anymore, and they don't respond to the sensations of pain that they would think they should. Oftentimes a elderly person dies of a heart attack and you have no idea that they really had cardiac disease because they didn't ever complain of any chest pain. Just one day they just fell over. And so that's not at all uncommon in the elderly. And then variant angina, sometimes referred to as vasospastic angina, is usually associated with coronary artery stenosis. In other words, the vessel thickens and stiffens. It narrows as well, so that thickness of a vessel means there's less room inside the vessel. The lumen reduces, and so it's a thickening, stiffening of the arteries. It may or may not be plaque buildup. It may be just vessel damage. It may even be something that occurs more as a genetic issue. In variant or vasospastic angina, you will have pain that occurs during rest or with very minimal exercise, and frequently at night. So this one's a little weird. They don't do anything and they have chest pain, or they lay down to sleep and then they have chest pain. So these are the chronic ischemic heart disease. So that takes us through all of the coronary artery disease that you're responsible for.